Glaucoma is the leading cause of irreversible blindness, and cases continue to grow year on year. Most anti-glaucoma medications in multi-dose bottles contain preservatives, which could cause ocular surface disease that leads to deleterious outcomes such as reduced quality of life, reduced adherence to treatment, increased rate of surgical failure and medication-related morbidity. But with Suntan's preservative-free glaucoma treatment, you could be the guiding star in your patient's journey. Start preservative-free therapy for naive patients who react badly to treatments with preservatives, or younger patients who require long-term treatment. Alter treatment by switching to preservative-free treatment for patients intolerant to OSD. Replace treatment for pre-surgical patients to reduce risk of OSD and reduce surgical failure rate. Suntan's preservative-free Tuflopros effectively controls IOP with high response rate, high tolerability, and reduced risk of OSD, making the treatment more comfortable and improving the quality of your patient's life.
Saya merasa semakin lama penglihatan saya secara bertahap semakin buram, dan itu mulai mempengaruhi pekerjaan saya. Sepertinya obat tetes mata yang diresepkan pada saya sudah tidak memberikan efek.
Apakah dokter memiliki pasien dengan keluhan yang sama? Penelitian dari Takagi tahun 2016 menunjukkan bahwa terdapat penurunan tekanan intraokular yang signifikan pada pasien naif yang diterapi menggunakan kombinasi Taflopros 0,0015% dan Timolol 0,5% selama 3 bulan. Penelitian yang sama juga menunjukkan bahwa pada pasien yang sebelumnya menggunakan monoterapi PGA, baik itu Latanoprost, Travoprost, ataupun Taflopros, kemudian beralih ke kombinasi Taflopros 0,0015% dan Timolol 0,5%. akan mendapatkan penambahan penurunan tekanan intraokular yang signifikan dari baseline. Mengapa pasien lebih memilih menggunakan Taflopros dan Timolol Fiction Combination? Marilah kita simak hasil penelitian dari Nakamoto tahun 2018 berikut ini. Dua penelitian lain dari Hyodo tahun 2010 yang berjudul Evaluation of Prostaglandin Analog Glaucoma, Eye Drop Container Usability, dan Investigation of Usability of Glaucoma, Eye Drop Bottles by Elderly Patient menunjukkan bahwa desain dimple bottle dari Sun Pharmaceutical terbukti lebih mudah digunakan oleh pasien glaucoma, terutama pasien-pasien yang sudah berusia lanjut. Apa yang dimaksud dengan desain dimple bottle? Mari kita simak fitur-fitur dari dimple bottle berikut ini. Adanya celah yang jernih pada kedua sisi dimple bottle memudahkan pasien untuk bisa melihat sisa obat yang masih tersedia dalam botol. Fitur berikutnya adalah desain tutup dari dimple bottle yang berbentuk segi 6, sehingga memudahkan bagi pasien untuk membuka tutup botol pada saat hendak meneteskan obat. Selanjutnya adalah bentuk botol yang dilengkapi dengan lekukan pada kedua sisi botol, yang memungkinkan botol obat lebih mudah dipencet, sehingga pasien tidak perlu mengeluarkan banyak tenaga pada saat meneteskan obat. Fitur ini sangat bermanfaat terutama bagi pasien-pasien yang berusia lanjut. Fitur yang berikutnya adalah desain inovasi dari ujung botol yang dilengkapi dengan katup yang berfungsi mencegah terjadinya kebocoran dan menjamin ukuran tetesan yang seragam di setiap tetesan obat. Selain itu, desain lekukan pada ujung botol juga mampu mencegah obat yang keluar dari botol tidak melebar ke bagian sisi-sisi dari botol setelah penetesan. Dan kini, Tapcom dengan dual power in every drop akan tersedia di Indonesia mulai dari bulan November 2021 dengan 3 keunggulan. Pertama, efektif menurunkan tekanan intraokular pada pasien naif. Kedua, efektif menurunkan tekanan intraokular pada pasien yang beralih dari monoterapi prostaglandin analog lainnya. Dan ketiga, preferensi pasien yang tinggi terhadap dimple bottle.
Alright, thank you so much. Assalamualaikum warahmatullahi wabarakatuh. Hello, sawadika. Good afternoon and evening Indonesia. Good afternoon Thailand. Good day for our friends from all the rest of the world. It must be evening and night in Pacific, Australia and New Zealand, afternoon and evening in Asia, morning now in Europe and Africa, early morning in North America, Central America, and South America. First and foremost, thank you everyone for coming. Welcome to this international webinar that is attended by participants from 65 countries of 6 continents around the globe. We are gathering this day, all nations, citizens of the world, to be united for helping the people against blindness. Welcome to our 22nd episode of Distinguished Maestro lecture. I am Gede Pardianto from Indonesia. Let's start the webinar. To honor the origin country of this webinar, please pay attention to Indonesian national anthem. Thank you so much. To honor the origin country of our distinguished speaker, please pay attention to Thai national anthem. All right, thank you so much. Ladies and gentlemen, the great Maestro this time will be Dr. Kessara Pathanapitoon, a master, a guru, a friend of mine, a researcher, and a scientist. Dr. Kessara is a professor of ophthalmology at Department of Ophthalmology, Faculty of Medicine, Chiang University of Thailand. She was recently a president of Thai Ocular Immunology and Inflammation Society. Dr. Kessara is a glaucoma and uveitis specialist at Chiang Ram Hospital. She is instructor of glaucoma and uveitis specialist at Department of Ophthalmology, Faculty of Medicine, Chiang University of Thailand. She holds certificates for uveitis and glaucoma fellowship from the University of British Columbia, Canada. And she is Doctor of Philosophy, graduate from Utrecht, University of Netherlands. Dr. Kessara has conducted so many research. She has published more than 50 papers at international journals and books, and much more in any international meeting around the world. Now, she is going to deliver the Maestro lecture to hundreds of participants from more than 65 countries of 6 continents around the world. Wow, that is Fantastic. At this very moment, she will present a very important topic with the title Maintaining Glaucoma Patient Quality of Life through Holistic IOP Management. It will be a really fascinating topic. Now, we are learning from the lady who is Grand Maestro in this field. So be prepared. Fellow ophthalmologists, let's pay attention to Professor Kessara Pathanapitoon. So, Kessara, Kate, we are counting down for you. 5, 4, 3, 2, 1. Time is yours. Lift off. Applause. God with Professor.
Hello everyone, thank you Professor Gede for the kind introduction and thank you Santin for inviting me to speak. It is my honor to join in this SMEC Eye Hospital meeting. I have no financial to disclose. My talk will be covered in three main topics, including holistic glaucoma management, using quality intraocular pressure control concept to maintain patient quality of life. Then I will talk about prostaglandin, what makes differentiation among prostaglandin molecules. The last is to align with the quality intraocular pressure control. Paradigm has shifted to the preservative-free glaucoma treatment. Multi-factors are overlapping in etiology of the glaucomatous damage. Intraocular pressure is recognized as the most significant factor in development as well as the progression of the glaucoma. Apoptosis, local ischemia, a balanced immunity, changing in the lamina cribosa, and low CSS pressure are also contributed to the pathophysiology of the glaucoma. So far, lowering intraocular pressure is the only proven means to slow or control the glaucoma progression. In study of those at the high risk of developing glaucoma, which is from the ocular hypertension treatment study, and those with the early to moderate glaucoma from the early manifest glaucoma trial and the collaborative initial glaucoma treatment study, and those with the more advanced glaucoma from the advanced glaucoma intervention study. Our goal in treating glaucoma patients is to maintain the patient visual function and promote their well-being and the quality of life at a sustainable cost. Quality of life are influenced by their visual function. The psychological impact of having a chronic progressive sight-threatening condition, the cause and the side effect of the treatment. The effect of the visual function on the quality of life is variable. Patients with advanced visual loss in both eyes may greatly reduce in their quality of life, so early diagnosis as soon as possible maximize efficiency of our treatment and minimize the risk or the side effect to enhance the adherence and the key to success. Several factors has been identified as the risk for glaucoma progression. Some factors can be modified or improved, including elevated eye pressure, intraocular pressure fluctuation, decreasing in ocular perfusion pressure, and the poor compliance. Some factors, for example, the thin CCT, pseudoexfoliation, or low corneal hysteresis, though unmodifiable, but these factors can provide us the better prediction for the progression. I would like to emphasizing that to achieving in glaucoma treatment, we should base on what called quality-based intraocular pressure control, which is the required holistic approach comprised of factors including mean intraocular pressure reduction, the response rate of the medication, which defined as the intraocular pressure should reduce at least 10 to 15% from the baseline for the PGA. The 24-hour intraocular control, the long-term intraocular pressure control, and the visual field stability. And the last is the patient adherence or compliance. I would like to briefly touch on each aspect in my presentation. First is the mean intraocular pressure reduction. The target pressure is the upper limit of intraocular pressure estimated to be compatible with the rate of the progression. Sufficiency to slow to maintain the vision-related quality of life. In most patients with advanced glaucoma, reasonable life expectancy, low untreated intraocular pressure, or having the risk of the progression such as dyshemorrhage and thin CCT, aggressive intraocular pressure lowering treatment is recommended. Treatment intensity should be individualized to the need and the rate of the progression of each patient. The aim is that the patient should not die before dying. Progression rate differ very much between patient and the type of the glaucoma, from rapid to very slow. The risk of encountering loss of quality of life from the glaucoma should determine the target pressure, intensity of treatment, and the frequency of the follow-up. The second aspect of the quality-based intraocular pressure control is the response rate. As already mentioned, that intraocular pressure should reduce at least 10 to 15% from baseline for the PGA. So intraocular pressure that reduce less than 10 to 15% from baseline may define as the non-responder. The poor response to one PGA might respond to another agent within the same class, so the guideline recommended to switch the drug before adding a second drug. The study in the normal tension glaucoma regarding to the non-responder to the PGA found that travoprost has the least percentage of non-responder when compared to ladenoprost and the travoprost. In clinical setting, we know that oftentimes we may make a very important decision based on the single intraocular pressure data that we obtain in the clinic. But this is not insufficient, as intraocular pressure has the dynamic behavior, and the peak intraocular pressure often occur outside the clinic hours. A wide range of terms has been used to describe intraocular pressure change over time. These include peak, trough, fluctuation. The term nocturnal will mean measuring during sleep, and the circadian will be defined to be within 24 hours. Which one is more important? Mean, peak, or fluctuation? Intraocular pressure can be categorized according to the period of time. The first is instantaneous, is variation that occur over a second, caused by saccade, blink, eye rubbing. Diurnal nocturnal variation occur over 24 hours, which may explain by postural change associated with blood pressure and episcleral venous pressure change, or the fluctuation in the cortisol level. The short-term fluctuation is variation that occur over days to weeks, and the last is the long-term fluctuation, which occur over months to years. Recently, researchers have been trying to study the relationship between this 24-hour intraocular pressure fluctuation and the visual field outcome in glaucoma patients using several methods, including home tonometer, contact lens sensor, as well as their implantable pressure sensor, but these approaches are not practical in the clinical practice. Intraocular pressure tend to spike in the nighttime or in the early morning, either due to normal circadian pattern or physiologic position. The peak intraocular pressure occur outside the office hour in and up to 45% of untreated pseudoexfoliation glaucoma. When treating glaucoma, which is the 24-hour disease, we should consider the effect of the medication, not only reduce the peak, but also 24-hour intraocular pressure control. Sustaining a constant intraocular pressure while reducing peak may be as important as lower intraocular pressure in terms of the disease progression, especially in the patient with the low mean intraocular pressure, which can be achieved by the prostaglandin and the topical CRI, but not with the beta blocker and the alpha-2 agonist as shown in this graph. Several studies shown that long-term intraocular pressure fluctuation may be an independent risk factor for the visual field progression. Advanced glaucoma intervention study demonstrate that long-term intraocular pressure fluctuation is associated with the visual field progression in patients with low mean intraocular pressure, but not in a patient with a high mean intraocular pressure. On the contrary, in early glaucoma, fluctuation is not significant risk factor for the progression. This graph from the Advanced Glaucoma Intervention Study or AG study, the y-axis indicates the change in the visual field deterioration score, while the x-axis is for the duration of the follow-up. As you can see that noted by the orange color, this eye with the individual intraocular fluctuation of 3 or greater millimeter mercury shows significant visual field progression, as opposed to the eye that show in the blue color with intraocular pressure fluctuation of less than 3 millimeter of mercury. Each millimeter of intraocular pressure increase in this intervisit fluctuation increase the risk of the field progression by 30%, which is quite significant. This emphasizes that this long-term intervisit intraocular fluctuation is an independent and strong predictor than the mean intraocular pressure for the visual field progression. This table shows 24-hour efficacy of the topical glaucoma medication, suggested that aqueous suppressant, including beta blocker and the alpha-2 agonists, except the TCRI, have little effect on intraocular pressure at nighttime because of the aqueous humor production is already at a basal level during sleep. Prostaglandin have replaced the beta blocker as the first choice or the first line therapy because they are most effective intraocular pressure lowering agent and effective for 24 IOP control by increasing the uveal scale outflow and maintain good efficacy at night and produce more stable intraocular pressure control than other medication that suppress aqueous humor production. It is also lack of systemic side effect and require just one daily dose. In patients who are receiving beta blocker, the potential systemic side effect, including bradycardia or decreasing in blood pressure, can lead to potential decrease in ocular perfusion pressure, which is one of the risk factors for the glaucoma progression. As already mentioned, that why the mean intraocular pressure lowering effect between PGA may be similar, but patient individual response to PGA can be vary. When looking at the structure of the lateral pores, travophores, and the bimotor pores, they are similar to the original PGF2 alpha that contain a hydroxy group in the 15th position of the carbon skeleton. This hydroxyl group in the 15th position was thought to be essential for the exhibition of the prostaglandin activity. Travophores is a new PGA derivative containing difualine in the 15th position of the prostaglandin skeleton to enhance the affinity for the FP receptor and prolong ocular blood flow, improving effect. With the difualine in the 15th position of the PG skeleton, increase the travophores capability in binding affinity for the FP receptor over other PGA, which is essential for the exhibition of PGA activity. In early and recent clinical trials supported that travophores was an effective, well-tolerated and safe medication both in treatment-naive patient, add-on or replacement therapy in a patient with unsatisfactory intraocular pressure control and or poor tolerability issue with their former medication. Overall, intraocular pressure lowering effect of travoprost was similar to that demonstrated through the travoprost, latanoprost, or bimatoprost in patients who were intolerant to the latter three PGA. Recent multi-center retrospective cohort study from Korea on the long-term effectiveness and the safety of the travoprost and latanoprost in POAG or normal tension glaucoma patients demonstrated that there was no statistically significant difference in intraocular pressure change from baseline between the three treatment groups. All had similar effectiveness in reducing intraocular pressure. The study also showed that travoprost provide long-term intraocular pressure control with visual field stability over 5 years with no statistically significant difference among PGA of these three PGA. When comparing 24 efficacy of the preservative-free travoprost with latanoprost, it had been shown that travoprost provides significant greater reduction in mean and peak intraocular pressure, as well as the greater reduction in 24 intraocular pressure control, especially at night time, and when compared to the latanoprost. An investigation of the tolerability and intraocular pressure reducing effect of the preservative-free travoprost in patients who previously exhibited ocular surface side effects from other PGA demonstrated that travoprost maintained intraocular pressure at the same level as other PGA, but was better tolerated with statistically significant improvement of all symptoms, including stinging, burning, itchiness, foreign body sensation, and significant improvement of in tear backup times, conjunctival hyperemia, and the fluorescein staining score, indicating that there was the lessen of the ocular surface damage. And the last aspect of quality-based intraocular pressure control is compliance. We all know that adherence is very significant and very important in glaucoma management because the drug don't work in the patient who don't take them. Patient compliance is a well-known issue in the medical treatment of the glaucoma. A study comparing adherence and persistence across several chronic medication classes found that adherence to the prostaglandin eye drop, which is our first-line drug, was lower or almost lowest than other therapy. The collaborative initial glaucoma treatment study showed that patients who are reporting more missing dose of the medication tend to have more visual field loss. This is a clear and significant link between the poor adherence and the visual loss, and emphasizing that helping the patient improving their glaucoma adherence is very critically needed. Many factors are associated with non-adherence, including physicians who lack of communication with patients, patients themselves who lack of concern about their disease, the ability to apply the drop correctly, and many other factors. Regarding to the medication, safety and the tolerability, complexity of treatment, cosmetic as well as the cost, all of these factors could affect patient adherence. And the last is the provider or the policy. This could affect reimbursement and the expense of the medication. The ocular surface disease is the common condition that exists in many of our glaucoma patients, with higher prevalence of the MGD, tear film instability, dry eyes, toxic keratitis, contact dermatitis, and the allergic conjunctivitis. The use of the BAK containing medication in this patient may aggravate the symptom. Patient comfort and visual function should be concerned, as this problem could influence adherence to the therapy, the quality of life, and the personal satisfaction. Anti-glaucoma drugs have been available for more than 140 years. Most of them contain BAK with difference in concentration, as shown in this slide. Latanoprost and the bimatoprost 0.01% have the highest concentration of BK, which is 0.02%. When managing glaucoma, we must concern not only with the glaucoma agent ability to lowering intraocular pressure, but also whether it is preserved with the BK and how much of it in concentration. The extensive literature review from Professor Baldwin et al. In 2010 demonstrated that the toxic action of the preservative to the ocular surface was observed in vitro and in vivo and associated with the disruption of the tear film inflammatory change in the conjunctiva. In clinical practice, it can aggravate symptoms and signs of the ocular surface disease, which can lead to discomfort and the poor compliance. The long-term toxicity of preservative could also inhibit intraocular pressure control due to its effect on the trabecular network and filtration surgery failure. 11 years later, the latest review again from the Professor Baldwin et al. In 2021 confirmed by the vicious cycle effect on ocular surface disease due to the long-term administration of preserved anti-glaucoma treatment containing BAK, which is the most prominent and visible consequence of the inflammation. This progressive vicious cycle, characterized by the progressive inflammation caused by inflammatory infiltrate and the cytokine release diffuse into the deep structure within the eye, leading to the increase of the resistant outflow, which clinically appears as the progressive loss of efficacy of our medication and require additional drug to control the intraocular pressure. The more drug, the greater the toxic reaction, leading to a higher intraocular pressure and eventually surgery with a negative impact on the filtering surgery failure, which is influenced by the inflammatory change within the within the anterior segment. This retrospective study on 128 glaucoma patients who undergone trabeculectomy and the impact of the preservative on future surgical success found that the time to surgical failure in patients receiving higher preoperative daily dose of BAK was significantly shorter than in patients who have less BAK exposure, and support the potential adverse effect of preservative on the surgical outcome to the present medication used in management of the glaucoma. At this time, most medications are still preserved in multi-use bottle, but there may come a time when all topical ophthalmic medications are packaged in preservative-free unit dose. An investigation of the tolerability and intraocular pressure reducing effect of preservative-free in patients who previously exhibited ocular surface side effects from preservative-added medication showed that after switching to preservative-free medication again, there was a statistically significant improvement of symptoms including stinging, burning, irritation, foreign body sensation, and signs including blepharitis, fluorescein staining, and a superficial punctate keratitis. So, choosing treatment with greater tolerability may help patients adhere to the therapy. Preservative-free eye drops have been developed to reduce exposure to preservative and lessen the ocular surface problem, resulting in a better tolerability, intraocular pressure control, and adherence. Let me share 3 cases experience that we can improve ocular surface problem by reducing BAK exposure using the new PGA 12-pause preservative-free. The first case is, you can see that there was the less conjunctival hyperemia after switching from other PGA to 12-pause preservative-free using the objective assessment from our own developed software called Chiang Automate Conjunctival Hyperemia Grading Software, showing that there was less strong red area of considerable vessel after switching to tropopause preservative-free, as well as the corneal staining using the same software as shown in the photo with 75% reduction of the punctate epithelial erosion. Let's move to the second case. This is a 75 years old female underlying diabetes and diagnosis of POAG. Her current medication was latanoprost and the tumoral and complaint of eye irritation, redness, and the photosensitive. Her right cornea showed epithelial defect with fluorescent staining of the corneal region that looked like the dendritic lesion. A smaller corneal pseudodendritic lesion was also found on her left eye. At this point, the differential was either pseudodendritic from dryness or prostaglandin-induced herpes-simplex keratitis. The photograph on the left shows herpetic keratitis induced by the use of the topical steroid after cataract surgery from another patient, demonstrating true dendritic lesion with terminal bulb, compared to the pseudodendritic lesion from dryness from this patient. So I stopped latanoprost and tumoral and switched to tropopause preservative-free and 0.3% hyaluronic acid preservative-free. At 4-week visit, the epithelial defect healed with minimal punctate epithelial erosion in both eyes. Intraocular pressure reduced from 18 to 16 millimeter of mercury with only 1 drop of the medication. The last is the 74 years old female with the diagnosis of CACG. She has tracheotomy on the right eye and laser iridotomy on the left eye. Her current medication was bimatoprost, bimranidine, and benzeramide, with intraocular pressure ranging from 15 to 22 millimeter of mercury. As you can see from this photo that her both eyelids show severe bimoment gland obstruction with toothpaste-like meibum and the inflamed eyelid. The cornea shows superficial corneal pannus together with the follicular conjunctivitis in both eyes. Anterior chamber show 1 plus cell with the diffuse medium size of KP. The diagnosis was severe bimoment gland obstruction dysfunction from the BAK toxicity and the allergic and the contact dermatitis from the bimranidine, as well as the anterior uveitis that was induced by bimranidine. So I stopped her all of her medication, giving her acetazolamide, the preservative-free the methylprednisolone to reduce the inflammation, together with the warm compress and the lid scrub. Uveitis workup came back all negative. 2 weeks later, after stop all of medication, her ocular surface inflammation was much better improved. Bimoment gland dysfunction or MGD, the pannus have been improved and their inflammation has gone. KP and anterior chamber cells was disappear. Cataract surgery was performed after the inflammation subsides, and she was on the tropopause preservative-free with the pressure of 10 with less MGD. I would like to summarize that to maintain the glaucoma patient quality of life through the holistic approach, we can start with the differentiation, the type of the glaucoma, to primary, secondary, open or closed, with or without pupil block. Assess the severity of the glaucoma to early, moderate, or severe glaucoma, setting the target pressure and control it with the quality base according to several aspects as already mentioned. Monitoring whether there is the progression, including the length of the progression, looking for the ocular surface problem, especially in those with medically treated, concern about the cosmetic problem, complexity of the treatment regimen, the cost and the compliance, the ability to apply the drop correctly, and finally lifestyle and the life expectancy. Considering patient perspective, as they may not concern about intraocular pressure, as we do, but they would like to maintain their physical activity, including reading, writing, the risk of falling, as well as the emotional, environmental, and patient-reported experience outcome. When we start to think about the glaucoma management in the context of the ocular surface disease, common symptoms of OSD include variable and intermittent blurred vision, itchiness, burning, stinging, grittiness, redness, irritation, dryness, and excessive tearing should be assessed. For the examination, there are 5 assessments that we should look for, including the lid, tears, cornea, inframe, and the nerve. When we look at the eyelid, we should search for MGD, look for tear film instability or tear backup time, corneal staining or superficial punctate keratitis, inflammation of the eyelid and the conjunctiva, and the last is the nerve sensation. The glaucoma patient who have been used the topical medication for a long period of time tend to have less corneal sensation or corneal hyperesthesia. What would be the role of the preservative-free medication in our glaucoma patient? I think preservative-free anti-glaucoma medication have the role especially in patients with the ocular surface disease, the young patient who require long-term use of the medication, patient who require 2 or more medication, as well as the patient who tend or plan to have the future surgery. All this patient profile can benefit from the less exposure to the BAK preserved in the anti-glaucoma drug. In summary, quality intraocular pressure control together with the good patient adherence are important for managing glaucoma. This holistic approach involves not only a number of intraocular pressure related issues, but patient related factors. PGA helping to achieve goal of therapy in glaucoma because they are most effective intraocular pressure lowering agent and effective for 24-hour control with once daily dose. Data supporting that the use of the travoprost in Asian patients have consistently demonstrated that travoprost is sufficient in reducing intraocular pressure, offer the uniform day and night intraocular pressure control with the long-term visual field stability and a favorable safety profile, reducing ocular surface problem because it is preservative-free, leading to high patient satisfaction, improve the vision-related quality of life and the treatment persistence. All these characteristics of the travoprost preservative-free are aligned with the quality intraocular pressure control concept. Thank you very much for listening. I would like to hear your opinion and looking forward for the discussion.
Thank you so much, Professor. What a lecture. Magnificent presentation. That was incredible.
Yes. Thank you very much, Professor Gede. So, thank you again.
Thank you so much, Kate.
Yeah.
And fellow ophthalmologists, now we are approaching the question and answer session. Professor, I will read its question for you.
Yes.
The first question will be, dear Professor, in order for general ophthalmologists to understand the quality IOP concept, what are the key or the main or the most important highlights of each of the 4 elements that should be communicated with them?
Mm-hmm. Thank you very much, Professor Gede, for the question about what would be important message of each element that should be highlighted to the general ophthalmologist. Well, in the first element, which is the mean intraocular pressure reduction, I think how to target the pressure is the key, because the treatment intensity should be individualized to the need and the rate of application of each patient. The aim is that the patient should not die before dying, as I already mentioned in my lecture. The factor to consider when setting the target pressure include the stage of the disease, the life expectancy, the risk, and the rate of the progression. In addition to this is the intraocular pressure reduction method, Regarding to the medication, we should know intraocular pressure lowering effect in various types of anti-glaucoma medication with minimal side effect. In terms of the response rate, what is considered as a good response rate is the key. As already mentioned, that intraocular pressure should reduce at least 10 to 15% from baseline for the PGA. So intraocular pressure reduction less than 10 to 15% from baseline may be defined as the non-responder. And the timing of the intraocular pressure measurement to determine the response rate is after 4 weeks for the PGA, and sometimes can be additional 4-week waiting in patients with early glaucoma or poor initial response to the treatment. Another important highlight about the response rate is poor response to one PGA might respond to another agent within the same class. So guidelines recommend to switching before adding a second drug. Regarding to the 24-hour intraocular pressure control, the important is knowing that the glaucoma is 24-hour disease and the intraocular pressure fluctuation is the risk for the visual field progression, especially in the advanced glaucoma. And the peak IOP usually occur outside the office hour. So detection of the fluctuation is a challenge, and some patients can progress despite low IOP. Therefore, sustaining a constant intraocular pressure reduction as well as reducing peak are important in terms of disease progression, which can be achieved by prostaglandin because they are effective for 24-hour intraocular pressure control by increasing uveal scleral outflow, maintain good efficacy at night, and produce more stable intraocular pressure control than other medication that suppress the aqueous humor production, including beta blocker and the alpha-2 agonists, because they have little effect on intraocular pressure at night, as the aqueous humor production is already at the basal level during sleep. Talking about the long-term intraocular pressure control and the visual field stability, there is a need to improve awareness on importance of how to detect and the rate of the progression. There are some barriers, including the reliability of the test, the waiting time for the visual field testing. In addition, as we all know that structural change can occur before functional change, and we might see some patients that the visual field index drop very fast, and we call this effect is the snowball effect, that the visual field progress in the nonlinear rate. Therefore, looking just the functional change might be too late. The last but not least is the compliance. The key barrier to the effective glaucoma management are the poor adherence. So the clear communication, such as informing the patient beforehand of what side effect to expect from the treatment, is important to manage the patient expectation. Teaching the patient how to put in the eye drops and choosing the medication with a good tolerability and less side effect can improve the adherence. I think all of these are the key of each element. It is the short question, but long answer.
Thank you so much, Professor. The next question will be, excuse us, Professor, about the theory versus practice as glaucoma specialist. What are the challenges you experience in your practice in applying the quality IOP concept? Thank you in advance for your answer.
Yeah, this is a very good question because it's quite in clinical practice, in the real world practice. In the clinical practice, I think the most difficult or challenge element is 24-hour fluctuation, as we are unable to evaluate the nocturnal or early morning intraocular pressure. And home tonometer, contact lens sensor with the current cost are at 500 euros per eyes, or implantable ocular device are not widely available or practical in our daily practice. The second one is difficulty in determining peak intraocular pressure. Regarding to the use of water drinking tests to predict intraocular pressure fluctuation or determining peak, There are some previous papers, especially from the Brazilian group led by Professor Susana, that show the usefulness of water drinking test, but in clinical practice, I never use it because I think it is not practical, especially in the elderly patient. You have to drink the water, 1 liter of water in 5 to 10 minutes. It's very difficult for the elderly patient. And sometimes you never detect the peak. The third challenge is, as the glaucoma specialist, most of my patients are referred from other hospitals and had no record of untreated intraocular pressure. And this leads to difficulty in assessing the response rate and setting the target pressure. I would like to highlight the need to record and communicate the initial intraocular pressure to the specialist, documenting the time when measured, as well as the type of intraocular pressure measurement. But whether it is the appronation, the air puff, or tonopen. So we will know what would be the mean intraocular pressure reduction or the response rate of the previous medication and what should we do next. In terms of the visual field stability, it is hard to have a good quality or reliable of the visual field. On conducting 5 visual field testing every 2 years, it is hard to implement, especially when some patients are not good at undergoing the test. In clinical practice, patients undergo 1 or 2 visual field testing in the first 6 months and another one within the next 6 to 12 months, depending on the stage of the glaucoma, whether it is mild, moderate, or severe. However, as already mentioned, one thing that we should be aware of is that if we use only the concept of the visual field stability, this may be too late, as the structure usually progresses first, and some patients will experience the snowball effect. So in clinical practice, we should use both the structural and functional change in detecting the glaucoma progression. The last is identifying non-adherence, which is quite challenging, especially in those with the white coat adherence. And this can mislead the doctor. Several methods have been used to identify non-adherence, including cell report, physician report, the direct observation, and the electronic medical monitor. All of that will be my opinion on the challenge in applying the quality intraocular pressure concept in the clinical practice.
All right. Thank you so much, Professor, for your answer. And the next question, Professor, how can we encourage general ophthalmologists to look beyond tonometry for measuring and managing IOP? How can we increase the awareness of the importance of the concept of quality-based IOP control rather than quality-based IOP measurement alone?
Okay, thank you. To look beyond the tonometry, which is just a snapshot, because the time of intraocular pressure measurement is just 5 seconds per eye. Triennial measurement, which is 15 seconds per year, that has 31 million seconds. This indicates the inadequate evaluation. In theory, we can highlight the significance of holistic approach using the quality-based intraocular pressure via the webinar like this one, or the use of a case-based educational approach to demonstrate the implementation of the concept and the outcome of it. In addition, I think the free download Sentence MD app that contain a lot of knowledge content, including webinar video, are also a useful way for the communication. However, in the real world practice with the very busy clinic, most of us probably do not have time to go into much detail. This is the barrier to the implementation.
Thank you so much, Professor. The next question, dear Professor, I would like to ask, what is the minimum they must do? In example, what are the key elements of quality IOP that general ophthalmologists must strive to assist in clinical practice? Thank you so much.
Yes. As already mentioned, that the general ophthalmologist may be aware and understand the quality of intraocular pressure concept, but might not able to implement into the clinical practice due to the time constraint, the proper assessment using the good quality tools, communicating patient adherence, or the restricted reimbursement policy. For example, the access to the preservative-free medication. But I think the most easy and the straightforward key element to apply in the practice are the mean intraocular pressure reduction and the response rate. Why the 24-hour intraocular pressure monitoring is the most difficult one, and is something that even the glaucoma specialist is unable to implement. And I think the measurement intraocular pressure at different times, such as morning, afternoon, or evening, might help in some cases. Or you may take intraocular pressure measurement every 2 hours from 8 a.m. to 5 p.m. But this approach has easily stopped in my practice because the fluctuation can rarely be detected, and also to minimize the time for the patient in the clinic in the current COVID situation.
All right. Do you still have time, Professor?
Sure.
Yeah, okay, thank you. The next question will be from Dr. Ahmad Aiman Azhar. He is from Airlangga University, Indonesia. Thank you, Professor Kessara, for the knowledge. In your opinion, when should PGA be given? In the morning or at night, if it is associated with the IOP nocturnal cycle?
Yeah, this is a very good question. And I think it is quite difficult to say. As already mentioned, that the glaucoma is the 24-hour disease, and it is also the like a stiff upside that come at night, because the blood pressure will drop at night, and the peak IOP usually at nighttime. From the study, the pressure will be rise up at 2 a.m. as well as at 6 a.m., which is outside the office hour. So sometimes it's quite difficult to say, and the pattern of the pressure in each patient is different. Some people, the pressure peak in the morning, some people peak in the nighttime. So it is quite difficult to say. And this is something that even the glaucoma specialists, as I already mentioned, that it is quite difficult to tell which one is better as to 24 hours. But if you see the patient that progress despite low IOP with compliance, you know that this patient take the medication every time, they didn't have the white coat adherence, then it would be that the patient might have something that the spike. The profile of the patient that have something like this, first is normal tension glaucoma patient. As I already mentioned, again, the patient progressed despite low IOP without white coat adherence. The advanced glaucoma, the patient who have high chance to have developed higher intraocular pressure fluctuation, including pseudoexploration glaucoma and the angle closure glaucoma. So this profile of the patient will have a chance to benefit in the serial intrapressure measurement. But anyhow, sometimes you cannot detect it, as already mentioned.
All right, thank you so much, Professor. The next question will be, dear Professor Kessara, is there a patient profile that can particularly benefit from serial IOP measurement? Thank you so much, Professor.
Yeah, as already mentioned, is that first is the patient who progressed despite low IOP. And the second one is the normal tension glaucoma. And the third is the patient with the advanced stage of the glaucoma, that the fluctuation will be the risk factor for the progression. And the fourth is the patient who have the high intraocular pressure fluctuation, pseudoexfoliation, and the ankle closure glaucoma.
Thank you so much. The next question is from Dr. Chumiyong from Malaysia. What are the factors that you use to decide on what type of IOP, monofocal versus multifocal or IOP, for NTG or POEG, PTS, to provide them for reasonable distance or near vision, provided IOP and ocular surface problem are taken care of?
Yeah, this is a very good question. I think it needs to be also the individualized. That what is the type, what should we use? Is it monofocal or multifocal or either of? In the patient in the early stage of the glaucoma or have a less chance to develop the progression, I think that there might be a role with the new generation of the intraocular lens, including the multifocal or either of lens. But in a very advanced stage of the glaucoma, or who patient who have the risk to develop the progression like a pseudoexfoliation, because these patients, they especially in the pseudoexfoliation, the chance to develop the instability of the zone because of the zonulopathy, there might be a chance to develop later that the RL with subluxation, something like that. I would not recommend to do so. So the monofocal will be the best for them. So as it needs to be individualized, and you need to discuss with the patient also, because that after, if you use the multifocal IOL and you still need to use the anti-glaucoma eye drop, they might have a chance to develop the ocular surface problem, and they might complain because of the use of the multifocal IOL. Together with the ocular surface problem, this will have the development of the brow vision or the contrast sensitivity, something like that. So I think that it depends on what kind of patient that you have, first stage of the disease, and the type of the glaucoma and the ocular surface problem.
Thank you, Professor. The next question, thank you so much, from Dr. Chumiyong, also Professor. Yeah, thank you. The next question, excuse me, Professor, I'm curious about how does response rate data with a viable anti-glaucoma medication factor in your choice of preferred agent? Thank you so much for your explanation, Professor.
Yes, as already mentioned, that my preferred choice of agent will be PGA as the first line treatment because it has 24-hour intraocular pressure reduction effect with a single daily dose and high response rate, few systemic side effect, and had no associated tachyphylaxis like a beta blocker. However, the response rate may vary across PGA from its difference in the corneal permeability, the intraocular pressure drug metabolism, and the difference in the affinity for the PGA receptor. This may explain why some patients are refractory to one PGA, but respond to another. It is important to consider the difference in response rate of medication when selecting initial therapy, giving to the patient, and switching in the event of the poor response. The travoprost demonstrate a promising response rate with the low rate of non-responder, as I presented in my lecture, and can improve outcome by minimizing the probability of the non-response.
All right. Thank you so much, Professor. The next question, this is two questions. Dear Professor, I have two questions. One, what is the most challenging in terms of ensuring adherence in your patient? The second question, what existing strategies do you consider as successful or useful in optimizing patient adherence? Thank you, Professor.
Thank you, Professor Gede. This is a very good question. I think that non-adherence is a multifactorial phenomenon that can be influenced by several factors, including physician, patient, pharmacy, and the policy-related factors. As the glaucoma patient have no symptom or treatment have no obviously improvement, and this lead to insufficient motivation to adhere to the treatment. The patient adherence is a big challenge, even in a research study. It has never been able to achieve more than 60 to 70% of adherence despite patient being contacted on a regular basis. In my practice, the first challenge is the identifying non-adherence, the white coat adherence, which means that the patient increased adherence preceding a scheduled office hour, typically 2 to 3 days before visit, making it difficult to assess either adherence or long-term intraocular pressure level. The second is difficulty in communicating with non-adherent patient due to time constraint. And the last is the restricted reimbursement policy for certain medication, especially the preservative-free. The cost of medication is an issue in many developing countries. Though the generic medication are available, the quality of this medication is variable and the treatment outcome is inconsistent, as shown in several publications. My approach to improving adherence includes, first, I try to communicate, which is very important. Try to spend more time with our patient at first visit to explain the importance of adherence to the medication and ask them at the next visit whether they are using the medication, informing our patient on the potential side effect of the medication. I usually inform the patient that they may experience a bit of redness or discomfort in the eye, especially with PGA, that this is normal and will go away by itself. We may also ask the patient to set the alarm or reminder on their cell phone to help with the adherence. Explaining the patient about the importance of medication in stabilizing the disease by showing the visual field result. Then I will try to simplify the treatment regimen, giving the medication that are more tolerable and less problematic using the preservative-free medication or medication with better tolerability to lessen the ocular surface problem. That will be I think that will be the challenge and the strategy to improve the adherence of our patient.
Thank you so much. The information is very useful.
Yeah.
Professor, do you still have time?
Yeah, maybe for the last question.
There is two last question. It's okay?
Yeah, sure. Absolutely.
Okay.
Absolutely.
Yeah, okay. The next question, dear Professor, what are your thoughts on primary selective laser trabeculoplasty and early surgery? Please share your opinion with us. Thank you so much.
Yeah, this is a very good question. Where do the eye drop fit in the era of the intervention glaucoma? The options are recommended for patients based on their current stage of the glaucoma and the target pressure. I think the SLT can be useful in selected group of patients and can offer as a primary treatment in patients who are young, have high initial intraocular pressure, have problem with using the eye drop or the pre-existing ocular surface problem, and patients who have early to moderate glaucoma. So this patient profile will have the benefit from the primary SLT. According to the light study showing that using SLT as a first-line treatment seems to be cost effectiveness, but not significant difference in health-related quality of life compared to the medication group. Thing to consider is that only 5% of patients in trial had severe stage of glaucoma. And the real-world study from UK found that SLT worked only 50% in the first year. Without the responsibility of daily medication, patient may forget that they have the glaucoma and fail to follow up. So it is important to note that intraocular pressure may rise again after 1 year. It does not cure the disease, and thus important to follow up with the patient. In my view, it is less likely that SLT is going to sufficient, and I think that medication still have the role. In patients who need adjunct in moderate to severe glaucoma, in my patient population at the university hospital, 60 to 70% had advanced stage of the glaucoma and aging people, and lots of comorbidity. The drop still have quite an important role in my population, with different kinds of the dry drop, including low kinase inhibitor, PGE2, that has no side effect of the prostaglandin associated periorbitopathy, and nitric oxide donating prostaglandin may provide more options in the management of the glaucoma. Regarding to the early intervention glaucoma in managing patients with angle closure, according to the EAGLE study, comparing the effect of the clear lens extraction and laser iridotomy in PAC or PACG, demonstrated that clear lens extraction are more cost-effectiveness with higher health and vision-related quality of life in lens extraction group, but higher risk of sonoropathy and inducing early presbyopia should be considered. And last is now we are in the mixed era in managing patients with open angle glaucoma. I think it is depend on which type of mix that have been used, whether it is the canal or trabecular based that you can cut, dilate, or stent, or bleb based mix that you can call minimal invasive bleb surgery. It seems that bleb based mix can be adapted in advanced glaucoma, but still there are little data on mix regarding to the long-term evidence on the cost effectiveness, improving in the quality of life, as well as the availability or reimbursement in developing country. These problems are also an issue that we need to consider. That will be my thought on the early intervention of the glaucoma or the early surgery or SLT.
Thank you, Professor. The next question from Dr. Paul Konstantin from Romania. Excuse me, Professor, what time the patient should instill taflotan at the night time?
It should be still at the nighttime. Regarding from the study, it
What
normally time? At the nighttime will be the best time, because the effect of the effect of the medication will be about 6 hours after it's instilled the eye drop, which in the peak in the morning. So you should put the eye drops at nighttime. But anyhow, if some patient work at night and they sleep in the morning, they would say that, is it possible to put in the eye drop in the morning? I think it's also can also, because with their mechanism of action that they increase the uveal sclerofold and the 24-hour control IOP. So it can be also used in the morning, but the best will be at nighttime, as already mentioned. Yes.
Thank you so much.
Because the peak of the effect will be 6 hours after that.
Yeah, that information is very, very useful. And the last question from Dr. Morteza Vifar. He is doctor from Iran. What is the role of MIGS procedure in comparison to medication in changing patients' quality of life, Professor? Thank you.
Yes. Yeah, as already mentioned that right now we still have very little data. There is a retrospective or prospective, but not very much on the mixed outcome, comparing with the medication in terms of the patient quality of life. So it seems that they might improve in some patients, but still we have some more data need to be consider, because this kind of the data, most of them are from Europe. And the problem is that we still have a problem on the reimbursement, as well as some mix that low cost, like a GET, sometimes that we can also use, but it depends long-term outcome. I think we still need to be concerned, and it still need to be studied. More research need to do in terms of the patient quality of life when comparing mix to the medication.
All right, very explicit.
Yes.
Many by our super maestra at this very moment. Great speaker, great audience, so impressive.
Thank you so much, Gede.
Okay, well, we are spreading love, care, peace, and tranquility on earth. Thank you, SMEC Group. Thank you, ID Sumut. Thank you, Perdami Sumut. Thank you, Anak Sudarti Foundation. And thank you, all committee. Thank you very much, PT Meiji and Santen Indonesia, Meiji Indonesia, Santen Asia Pacific, and Santen Vietnam for supporting us this very moment. Thank you, our distinguished participants, and to our maestra, Professor Kessara Pathanapitoon. Please send our regard to your family. Thank you so much, Kate.
Thank you all. Thank you all for listening, and Professor Gede and the SMCI Hospital and the Center for inviting me to join this meeting. Thank you so much. สวัสดีค่ะ Have a good evening.
Thank you. Thank you.
Thank you. Bye bye.
Bye, Professor.
สวัสดีค่ะ
สวัสดีค่ะ Thank you so much.
ขอบคุณค่ะ
Thank you so much, Professor.
ค่ะ
Thank you. Thank you.
Thank you. Bye bye.
Bye bye, Professor. Our distinguished participants, our next month on August will be international launching of the book of the intraocular power calculation. Hopefully, we will have Professor Steve Arsino from Canada, Professor Navin Rao, and Dr. Brent Kramer from USA, Professor Oliver Findel from Austria, Dr. Giacomo Savini from Italy, and Professor Marie-José Tassignon from Belgium. The link also will be sent via email. We will give to whoever joined the ceremony an e-book. We will give you an e-book, yes, for free. Furthermore, the certificate for this webinar will be sent hopefully before 2 weeks. Your participation is highly appreciated. We thank you. See you all. Thank you so much, all of our great friends. Wassalamualaikum warahmatullahi wabarakatuh.
Glaucoma is the leading cause of irreversible blindness, and cases continue to grow year on year. Most anti-glaucoma medications in multi-dose bottles contain preservatives, which could cause ocular surface disease that leads to deleterious outcomes such as reduced quality of life, reduced adherence to treatment, increased rate of surgical failure, and medication-related morbidity. But with Sunten's preservative-free glaucoma treatment, you could be the guiding star in your patient's journey. Start preservative-free therapy for naive patients who react badly to treatments with preservatives, or younger patients who require long-term treatment. Alter treatment by switching to preservative-free treatment for patients intolerant to OSD. Replace treatment for pre-surgical patients to reduce risk of OSD and reduce surgical failure rate. Sunten's preservative-free tuffelprost effectively controls IOP with high response rate, high tolerability, and reduced risk of OSD, making the treatment more comfortable. And improving the quality of your patient's life.
Saya merasa semakin lama penglihatan saya secara bertahap semakin buram, dan itu mulai mempengaruhi pekerjaan saya. Sepertinya obat tetes mata yang diresepkan pada saya sudah tidak memberikan efek.
Apakah dokter memiliki pasien dengan keluhan yang sama? Penelitian dari Takagi tahun 2016 menunjukkan bahwa terdapat penurunan tekanan intraokular yang signifikan pada pasien naif yang diterapi menggunakan kombinasi taflupros 0,0015% dan timolol 0,5% selama 3 bulan. Penelitian yang sama juga menunjukkan bahwa pada pasien yang sebelumnya menggunakan monoterapi PGA, baik itu latanopros, trafopros, ataupun taflupros, kemudian beralih ke kombinasi taflupros 0,0015% dan timolol 0,5%, akan mendapatkan penambahan penurunan tekanan intraokular yang signifikan dari baseline. Mengapa pasien lebih memilih menggunakan taflupros dan timolol fiction combination? Marilah kita simak hasil penelitian dari Nakamoto tahun 2018 berikut ini. Dua penelitian lain dari Hyodo tahun 2010 yang berjudul Evaluation of Prostaglandin Analog Glaucoma, Eye Drop Container Usability, dan Investigation of Usability of Glaucoma, Eye Drop Bottles by Elderly Patient menunjukkan bahwa desain dimple bottle dari Santen Pharmaceutical terbukti lebih mudah digunakan oleh pasien glaukoma, terutama pasien-pasien yang sudah berusia lanjut. Apa yang dimaksud dengan desain dimple bottle? Mari kita simak fitur-fitur dari dimple bottle berikut ini. Adanya celah yang jernih pada kedua sisi dimple bottle memudahkan pasien untuk bisa melihat sisa obat yang masih tersedia dalam botol. Fitur berikutnya adalah desain tutup dari dimple bottle yang berbentuk segi 6, sehingga memudahkan bagi pasien untuk membuka tutup botol pada saat hendak meneteskan obat. Selanjutnya adalah bentuk botol yang dilengkapi dengan lekukan pada kedua sisi botol, yang memungkinkan botol obat lebih mudah dipencet, sehingga pasien tidak perlu mengeluarkan banyak tenaga pada saat meneteskan obat. Fitur ini sangat bermanfaat terutama bagi pasien-pasien yang berusia lanjut. Fitur yang berikutnya adalah desain inovasi dari ujung botol yang dilengkapi dengan katup yang berfungsi mencegah terjadinya kebocoran dan menjamin ukuran tetesan yang seragam di setiap tetesan obat. Selain itu, desain lekukan pada ujung botol juga mampu mencegah obat yang keluar dari botol tidak melebar ke bagian sisi-sisi dari botol setelah penetesan. Dan kini, Tapcom dengan dual power in every drop akan tersedia di Indonesia mulai dari bulan November 2021 dengan 3 keunggulan. Pertama, efektif menurunkan tekanan intraokular pada pasien naif. Kedua, efektif menurunkan tekanan intraokular pada pasien yang beralih dari monoterapi prostaglandin analog lainnya. Dan ketiga, preferensi pasien yang tinggi terhadap dimple bottle.
Glaucoma is the leading cause of irreversible blindness, and cases continue to grow year on year. Most anti-glaucoma medications in multi-dose bottles contain preservatives, which could cause ocular surface disease that leads to deleterious outcomes such as reduced quality of life, reduced adherence to treatment, increased rate of surgical failure and medication-related morbidity. But with Suntan's preservative-free glaucoma treatment, you could be the guiding star in your patient's journey. Start preservative-free therapy for naive patients who react badly to treatments with preservatives, or younger patients who require long-term treatment. Alter treatment by switching to preservative-free treatment for patients intolerant to OSD. Replace treatment for pre-surgical patients to reduce risk of OSD and reduce surgical failure rate. Suntan's preservative-free Tuffelcross effectively controls IOP with high response rate, high tolerability and reduced risk of OSD, making the treatment more comfortable and improving the quality of your patient's life.